Okay, welcome. For you just joining us, I'm Dr. Anna Barrick, and I will be giving you some information about Propel tonight. So thank you for coming. Hello to all my friends out there who were kind enough to register. So I'm Dr. Anna Barrick, and I'm the owner of Newton Dental Associates. I own a group in specialty practice here in Boston, Massachusetts, and we're here tonight to talk about Propel. I'll tell you a little bit about myself, and we'll get right into the meat of things and get going. So here we go. There we go. So Dr. Anna Barrick, I'm an elite provider with Invisalign. I can tell you that I was doing cases for Invisalign primarily to do my restorative cases, and Propel has really taken me from a premier preferred provider to an elite provider. So I'm very grateful for that, and I want to teach you everything I know about this. I'm a graduate from Tufts University School of Dental Medicine. The handsome boy you see there is my Frank, my 150-pound Leonberger. This side just sums up me to a T. I have my Tufts sweatshirt on. I'm sitting in Nantucket on the boat with my very favorite friends. I'm a full-time dentist. I'm not a lecturer per se. I love this t-shirt because freaking miracle worker is not an official job title. I know you guys are hardworking and you live this every day. You tell patients they need a root canal and they say, can't you just do a filling? So I get what we do it all the time. And I am here tonight to help you do what you do better, to introduce you to Propel. Here's our standard disclosures. Let me just briefly go through this. I'm not employed by any dental company. I wish I owned stock, but I don't. I'm not a family member, and I'm not a consultant for them. I'm receiving an honorarium tonight for my participation. Please don't take photographs of my patients. It is the one thing that I will ask is that you do not share my patient photos. Respect them. They were kind enough to let me use their images in order to teach you. So tonight we're here to talk about the Barrick acceleration method. It was kind of formed from the first lecture that I was asked to do on accelerating Invisalign cases. And lectures tend to get whitewashed a little bit with erasing this company name or that company name. And so I'm really going to talk to you tonight about how I have incorporated Propel into my Invisalign or my clear aligner cases. And it's really been a phenomenal thing. We are coming in today to this webinar with all levels of providers. So I'm going to provide you some background and some basics on Propel, and then I'm going to give you my way of incorporating it into my office. So we are captured down to a 1 hour time frame here. So I'm going to run through the first part about Propel and sort of teaching. So for those of you who have used Propel in the past, this will be a little bit of review. Maybe you'll get a few nuggets you didn't have. And for those of you who have never used the product, my goal here is for you to get a deep enough understanding to feel confident to go out and do a case tomorrow. So let's think about acceleration. Let's get right into the meat of this. So I asked Siri about acceleration. And I said, Siri, what is acceleration? And she told me that acceleration is an increase in rate or speed of something. A more physics-based definition is that acceleration is the rate of change of velocity per unit time. My definition is how flippin' fast can I move teeth? That's what I really want to know, and it's a hot topic lately. So when we think about acceleration, a few months ago, an aligner company announced that 7-day wear was possible. When Invisalign came up with that 7-day wear was possible, can you change all patients in 7 days? Is this what it means? No, if you read the fine print from this, what it really said was, 1, at the doctor's discretion, meaning you're responsible, and 2, what is it based on? Is it based on the patient's physiology? Is it based on the movements? It doesn't really describe to you when 7-day wear will work. And I can tell you that, this was based on a very small group of patients, the study that they did. So a aligner company announced the 7-day wear. Well, that's acceleration from the 14-day standard wear. Munchies and Chewies are actually billed as a form of acceleration. For those of you who don't know what they are, various forms of rubber basically that your patient bites on for a set amount per day, every day. They're aligner seaters. They're going to stuff the aligners up over the attachments, making tracking better and therefore considered an acceleration. Vibrational technology, Accellident, one of the first companies to enter the vibrational technology, and now Propel has their VPro 5 out for the past several years. Again, vibrational technology, you're asking the patient to place an appliance between their teeth with their aligners on. These are aligner seaters. Manual osteoperforations. This is going to be the meat and the crux of our lecture tonight. I'm really going to teach you everything you need to know about manual osteoperforations. Since this is such a mouthful, I will use MOP for short, as well as I'll use the word Propel interchangeably with it, and I mean manual osteoperforations. Other ways to accelerate: surgery, Wilcke-Donics, P-Incisions, some pretty invasive procedures there. And last on my list is photobiomodulation, orthopulse being an example of light-induced acceleration. So in 2014, Dentistry Today, Dr. Brian Gray wrote an article about acceleration techniques for orthodontics at the time. And what he did was take each one individually and compare it and contrast it. And I found this beautiful chart, which I'm going to share with you. I highly recommend you go back and read the article. But I found this lovely chart, which for me sums up a lot of things. So allow me to share with you for a minute. The key is 0 is none, 1 is low, 2 is medium, and 3 is high. So let's look over here at effectiveness. We've got our methods to accelerate here, and we've got effectiveness. Well, I'm going to drive right down the effective line. 2, medium, Accellident. So Accellident for us will represent all vibrational technology. The pharmaceutical NA, BioLux NA, laser accelerated treatment NA, I'm going to skip all of those. I want something that's effective. I'm going to choose a way to accelerate my cases. I want an effective way. So 3 was high, so it looks like Wilcke-Donics and P-Incisions, the surgeries that we mentioned earlier, are very effective, and Propel. And by Propel, they mean the microosseous perforations. So these 3 are the most effective. Let's look at cost. So here, under cost, we have that there is a high cost associated with Accellident. Back in the day when Accellident first came out, they were $1,000 a unit. Until the more and more you bought, the cost reduced. And then as we look at laser accelerated treatment, as we look at Wilcke-Donics and P-Incision, we find that those are relatively expensive, medium and high cost. And then we get down to Propel, and we see that it's a relatively low cost in terms of ease of use. So ease of use would be a consideration. Accellident is medium easy to use. The surgeries are relatively difficult. Generally, they involve specialists. And Propel had a very, very ease of use. I am just clicking out of an announcement that keeps getting made. So for this reason, when I looked at that chart and we gauged cost and effectiveness together, this is reason enough for me to want to know more about Propel. It was the lowest cost and high effective treatment. So I want to know what happens when I put my accelerated orthodontics, my clear aligner or Invisalign therapy together with microosseous perforations. Let me introduce you to the devices. On your left-hand side of your screen, the single use is nothing that we use anymore. They're the older first-generation devices. The second device here is the RT, or the manual device. And this tip here, this light blue tip with the sleeve, that is the disposable piece of the unit. The lines here represent 3, 5, and 7 millimeter hash marks. I started out with this device. I did my first 75 cases with it. I still pick it up all the time currently. And then there's the PT, which is the manual driver. And the bit that's the burr bit here is the tip that you use patient to patient. So those are the 3 devices that we're going to be talking about tonight. Again, the one to the left is the older device. So let's talk about an introduction to osteoperforations. MOPs for short. 2 reasons why you want to consider microosseous perforation. The 2 benefits. 1, and this is exactly what I tell patients, why are we going to consider this? We're going to consider Propel because accelerating your orthodontic treatment, and 2, increase the predictability of orthodontic movement. And I think it is the second point that gets highly overlooked. We're always looking to speed this treatment along, but I will venture to you that ending your case when you expect to be done, having the movements translate from the ClinCheck that you approved into the patient's mouth and finishing predictably and at your last aligner is an amazing benefit, both in the cost and time it saves you, your patient's expectations are met, the reduction of additional aligners and what that means for your office and chair time. So we often speak here about acceleration, but I really want you to take a look as well that microosseous perforations increase the predictability of orthodontic movement. So let's look at the science behind the microosseous perforations. We have to ask ourselves, how fast can we move a tooth? And this applies to all orthodontic techniques. Well, we need to look at what affects tooth movement. The type of orthodontic movement. Are you tipping? Are you proclining? Are you intruding? Are you rotating greater than 20 degrees? The type of orthodontic affects the rate. The amount of force you use. If you're in aligner therapy with Invisalign, each aligner, unless you specifically ask in a reduction of movement, moves 0.25 millimeters. Wires, different technology, you can change the force on a wire. Bone density and quality affect tooth movement, the rate of tooth movement. You know, you can have a Viking type patient with just a jaw granite, or you can have a little old lady with birdie bones. So the density and quality of the bone. And number 4, the rate of bone remodeling. Let me bend your ear for a minute about osteoclast and osteoblastic activity. Osteoblasts are giving you bone cells and osteoclasts are eating them. Together, that process is how we move teeth through bone. And the process of osteoclastic and blastic activity is collectively known as bone remodeling. So now we're up to speed on what affects tooth movement. Well, it turns out that one of these factors is the most important in controlling the rate of movement, and that is bone remodeling. And so bone remodeling is influenced by an enzyme called cytokine, everyday enzyme you have in your body now. The second that you put aligners or brackets and wires on a patient, you increase cytokine. And cytokine has been shown as the basis for bone remodeling. It is going to, with an increase in cytokine, you're going to increase or activate your osteoclastic and osteoblastic activity. So this is why cytokine is such an important enzyme when we're talking about orthodontic tooth movement. Inflammation also plays a very important role in orthodontic tooth movement. What we know is that if you give anti-inflammatory medications, it significantly decreases teeth movement. And this is important even if you're doing a standard bracket and wire case, if you're currently having patients in your aligner therapy and they're taking copious amounts of NSAIDs, they're actually decreasing cytokine and inflammation there. In the animal studies, we also know that if you knock out the cytokine, this significantly decreases the rate of tooth movement. So what we're saying here in summation is that manual osteoperforations are going to cause a bone injury. Inflammation at the cellular level, not faces flowing, inflammation at the cellular level. This increases cytokine production, which increases the rate of bone remodeling and decreases bone density. This, my friends, this single slide in 4 sentences sums up manual osteoperforations. And this is what you tell your patients. We're going to, at the cellular level, create an inflammatory response. This increases cytokine production, which is an enzyme that controls all the rate of bone remodeling. And therefore, this is how we're moving teeth faster. But we already knew this. This isn't really new information. Procedures like vulcodontics and episiotomies that we talked about briefly a moment ago, they've been around for a long time, and we know they work. We know they speed up treatment time. But they're full-blown surgery. They're expensive. You need a specialist. There's big recovery time in some cases. I mean, my slides don't even look good to you. Hopefully no one's eating dinner during the presentation. So we knew that. So I will also turn your attention to a November 2013 article in the Journal of Orthodontics. And what we're looking at here is an NYU study about microosseous perforations. Again, this is back in 2013. I'm going to take you through the science quickly, but I'll leave this up for a moment in case anyone's taking pictures and wants to go back and read the full article. And what basically this NYU study did is, this is the same patient. A premolar was extracted, and we are going to be distalizing canines. You can see the tad appliance on both sides, on the left and the right side of the patient. What I need to tell you is that this is all that is here on the left side. On the right side, if you look carefully, you will see a little red spot here. And again, what has occurred is microosseous perforations were applied to one side of this patient and not the other. And they brought this patient back after 4 weeks. And here are the results. I mean, you'd have to go back to the first slide to see if this has moved at all. But clearly on the side where the Propel was used, where the microosseous perforations were placed, you can visibly and clearly see that tooth has translated. That tooth has moved. It is distalized. You know, the kid didn't even like this side. He stopped brushing it. I can't believe this is the published slide, but there it is. The kid didn't even brush the non-accelerated side. So I feel that significant movement. There's the science behind this. I'll give you the contraindications because they're related to the science we just spoke about. An ASA, systemically compromised patient, is someone who's hospitalized. ASA is the Society for Anesthesiology, the American Society for Anesthesiology. So this isn't a patient with diabetes. We're talking about systemic shutdown. So you're probably not doing a lot of orthodontics on this patient. Patients requiring chronic NSAID or steroid treatment. This is chronic. This isn't the person who takes an Advil once in a while when they get a headache. This is chronic use. And why? We just spoke about the reason. The reason for this is it decreases inflammation, and we are using a cellular inflammatory response. Patients who are treated with bisphosphonates. This is your osteoporosis medication. Bisphosphonates increase bone density. Again, we're moving through bone. We don't want to make a tougher medium to pull through. So those are your contraindications for acceleration with microosseous perforations. So let's get started. You're going to need a full mouth x-ray. This is not a patient of mine. I pulled this off the web, but this demonstrates that we're going to need a full mouth x-ray because you want to know where the roots of your teeth are. You want to know where your foramen are located. You want to know, is there a pin, a wire, a screw? These are the things you're looking for in your FMX. I also highly recommend you go find your movement assessment chart. This is actually a patient of mine here that you see. We will see her later on in the presentation. But to get to the movement assessment chart, you will go onto your VIP page, into your patient, and you will look under the word treatment. If you click that, there are 3 pages that come up. The first 2 are where to IPR and that sort of thing that you generally see put into the box with your cases. But the 3rd page there that I wish they would put up looks like this, and it's a movement assessment chart. And this is very important in getting started in thinking about your first cases because tooth movement, what type of movement we're doing, affects the rate we can move at. We said that earlier. So in this very simple chart, what Invisalign had done for you, clear are relatively predictable movements, but when they're showing you blue movements, these are moderately difficult teeth to move. And keep an eye on 20 and 21 down here because I will show you the case, and these teeth are black movements. These are advanced movements. These are your less predictable movements. These blue and black teeth are the teeth that will not move in 7-day tray wear just because you said to change them faster. So this is going to be, you're going to look at your FMX, your radiographs, and you're going to go to your movement assessment chart. Because the reason is that you'll track no faster than the rate limiting tooth. On the movement assessment chart we saw a moment ago, those 2 black movements, those advanced movements are my rate limiters. My case cannot proceed faster than I can move these teeth. So you need to consider what your rate limit are when you consider how fast you're going to progress through aligners. So this is how you'll begin to make determinations about this. You're going to check your tooth assessment chart. You know, eventually this will become second nature to you. You'll be able to look into the patient's mouth and you'll see rotations of greater than 20 degrees. You'll see difficult intrusions to make. You will see some of these less predictable movements, and you'll start to say, this is a case that's going to take me longer. These are the less predictable movements. These are my rate limiters. So you're going to look at the type and amount of movement, and then you're going to make your determinations on 7-day wear, 5-day wear, 3-day aligner wear. So let's look just briefly about what are easy predictable movements with aligners. Lingual constriction, anterior space closure. So I know you can't see me, but imagine a series of lower mandibular anteriors with space between them. Lingual constriction simply has that plastic squeeze together, constricts that space lingually. That is a very predictable, easy motion. Proclinations, tipping, especially anteriors. Tipping is a simple movement. And premolar expansion. What are some difficult, less predictable movements with aligners? Root torque. You are now tipping the root through bone. This is not crown tipping. This is you're actually moving a root, usually mesially or distally, but also you can torque buccally or palatally. Maxillary anterior intrusion. Let's think about 8 and 9 in a deep bite case. You know, for years everybody talked about how hard lateral incisors, maxillary lateral incisors are to move. And I'll proffer to you that it is not the little lateral incisor that's hard to move. Failed intrusion of 8 and 9 in your deep bite cases. When 8 and 9 do not intrude as your ClinCheck has predicted they will, you lose traction on your laterals. And AP changes are difficult. So when you're moving from a class 2 to a class 1 platform, moving anterior posteriorly and molar translation, these are less predictable and difficult movements. And you need to start to identify and think about these movements. What type of movement and how much movement? So people always ask, how many perforations do I put? Where do I put them? Let's start to look at how we're going to develop our case. So you are going to place your perforations left and right, or mesial and distal, of the root of the tooth or teeth you wish to accelerate. So you're going to put them left and right of the root of the teeth you want to move. You're going to place them in keratinized tissue. I was just asked on a group WhatsApp chat site about placing them in mucosa. I will tell you the preference is in keratinized tissue. If you need to, if the anatomy dictates it, if you've got little twangled roots together and you have no other place to put it, pull the mucosa taut between your finger and thumb. Pull it tightly and then place your perforation. It is not wrong, it's just more difficult. It causes a bit more injury. The keratinized tissue is very clean. It's a very clean way to do it. If you do not pull the mucosa taut, it winds around the vertex, causing more tissue trauma than is necessary. I'd like to keep it neat and clean. You're going to place ideally 2 to 3 perforations per site. So if we're doing maxillary central incisor number 8, let's say, I'll place 2 or 3 perforations to the mesial of the root and 2 to 3 perforations to the distal of the root. The more perforations you place, the more ideal it is, the better movement you're going to get. You're going to go on the anterior segment of the mouth, about 3 millimeters in depth. Around the premolars, you're going to perforate about 5 millimeters in depth, and around the molars, around 7 millimeters in depth. What I will tell you is that's a generalization. What is really important and what I need you to focus on is that we need to break cortical bone. You will feel this. Let's discuss the tactile sensation for a moment before we move on. When you are pushing the RT, the manual one, or the PT, the power-driven propel device, you will feel it spin through tissue quite easily, and then you will feel, especially in the manual one, you will feel the burr grab. When you feel it grab, just like a corkscrew going into a wine bottle, when you actually get that tissue bite into the bone, you will feel it. You will actually hear a change when you are on the power driver. You can actually hear the cadence shift. You can feel the burr grab and start to almost pull itself into the bone. That is what you need. You need to break cortical plate. But the guidelines for you are 3, 5, and 7 anterior premolars and molars. So let's look at where to perforate. If you look at the lower right corner, you're going to see this little molar graphic. You are going to place your perforations anywhere from the crest of bone to the apex of the root. You're not going to go lower, and of course you're not going to go higher just into tissue. You are going to place most of your perforations on the buccal surface. It is permissible and sometimes advantageous to place a palatal perforation. I do not use palatal perforations. What I want you to know is you're going to stay away from perforating near any anchorage devices like TADs, excuse me, or any teeth that you're using as anchorage teeth. Let me give you an example. If I am not moving my maxillary molars and I'm using elastics to distalize a mandibular canine, excuse me, I'm so sorry. You do not want to perforate around your maxillary molars. Those are your anchorage teeth. You are not looking to move those teeth. You are using your perforations around the roots of the teeth you wish to move. Again, so you're going to stay crestal to apex, and you're going to place your perforations mesial and distal. This is a wonderful slide, not so much in the words here, but to take a moment and to tell you there are 2 ways to use your propel acceleration and your perforations. Proactively, which is how I do all my cases. You've talked to your patient, yes, Mrs. Jones, we're going to move your teeth in 3 months instead of a year using propel, blah, blah, blah. You set up your case accordingly. You treatment plan it, you place your perforations, you guide your aligner wear, say every 3 to 5 days. A reactive approach is something you can get up tomorrow morning and use immediately. So say you are doing uprighting number 22, canine on the lower. This is a difficult movement. To upright, you are root torquing very often, and this is not an easy movement. And a canine has a giant, long, sometimes even a concave root. So if you are seeing your patient on a recall appointment and you find the upper looks fine, but you feel like your lower tray is not quite seating, you check your movements, and that canine should be in a different position than it is right now. You can stop right there. You can apply a little anesthesia. You can use perforations mesial and distal to the root of tooth number 22 in our example. You can return the trays. Make sure your patient is actively seating the trays, and you will watch that tooth start to track immediately. You can use language like, Mrs. Jones, this lower tooth is stuck, it's stubborn. We're going to use a little acceleration around this tooth to wake it up, to get it back on track so we finish your aligners as predicted. So there's a proactive and a reactive approach to using this. Occasionally you'll have a case and you treated the case proactively. You started off, you launched your aligners with microosseous perforations, and you have a very difficult, your rate limiting tooth is very difficult. You're nearing the end of the aligners and you feel that that tooth may be losing tracking. You can go back around the second tooth, that single tooth, and apply just a little perforations, again, mesial and distal to that root, and it will begin to move beautifully again for you. The number and patterns and spacing. This is the least critical part of this. You're going to do what the anatomy dictates. You can place one perforation, particularly between mandibular, those lower little incisors. Sometimes, man, those teeth are so crowded and so locked together. If you can get a single perforation between them, you have enough bone, and you feel comfortable between the roots. It's still advantageous, and I'll explain another benefit to that Propel offers that helps you achieve goal with those teeth when they're so tightly packed. 2 is what's recommended, and 3 is ideal. So you want to do 2 to 3 perforations, mesial and distal to the roots. The pattern doesn't matter. If you had all the spacing that you see at the bottom of this slide, you could put smiley faces in there. Generally, this vertical pattern, I will say, is the most used approach. Occasionally you'll get on the lower, again, if you have one of those canines that tips labially and then your incisors are over erupted next to them, a lot of times those teeth will touch at the top like a teepee, and you'll have this triangular bone in between. You can lay a triangular pattern down. Again, keratinized tissue is ideal. Hold the mucosa taut if you are in unattached tissue. So here's the benefit that I was going to talk to you about. Let's talk about osteoperforations. So you have a radius of bone stimulation around your perforations, 6 to 10 millimeters, depending on how many perforations you place. So in the example where we had very tight mandibular incisors, and you felt that maybe you could get 1 perforation, 2 perforations in between 23 to 26. I will tell you that on the mesial of your lower canines, if you place 3 perforations on each, they will have a radius of bone activation which will carry over to the right and to the left of those canines and activate and stimulate the bone at the level of your incisors. So this is a tremendous advantage. When we talked about placing a palatal perforation, we're really talking generally about a lateral, a maxillary lateral incisor that's palatal, that's locked out. I've had cases so bad where the central and the canine have this little teeny window, and if you look through it, right on there, the palate, we can see the lateral incisor. And so you can, and it's totally permissible to go up, numb the palate a little bit, and place palatal perforations. But numbing the palate is not the most comfortable thing either, is it? So, but what I will tell you is that if you put microosseous perforations to the distal side of your central and to the mesial side of your lateral, you will have the circumferential activation to that palatally placed lateral. So depending on the number of perforations, 6 to 10, this is going to last. This bone stimulation, the benefit we get from microosseous perforations, lasts about 10 to 12 weeks, about 3 months. And then you may consider reapplying. So you're going to use your movement assessment chart. You're going to look at the blue easy movements. Maybe you'll place 2 perforations, mesial and distal, to all of the teeth you want to move. Black, I would definitely recommend 3 on both sides of the teeth as you can. What benefits you here is that radius of activity from 6 to 10 millimeters circumferentially. And again, this is a tremendous benefit, especially with those little mandibular anteriors, when all you see is roots on the x-ray. And it's great because you have this peripheral effect. So in review the perforation depth, we said recommended 3, 5, and 7 anterior, 3 premolars, 5 molars, 7. But again, the real point here is to break cortical plate. That is all you need. So to start the procedure, you're going to review your treatment plan for where you're going to place your perforations. Use your movement assessment chart. You're going to look at your x-rays for root anatomy, frenums. You're going to avoid frenums. You're going to avoid foramens, obviously. You're going to numb the area to be treated, and Propel will tell you from the reps that you can use topical or local, and we'll discuss that in a few minutes. You're going to explore the surrounding tissue thickness, and then you're going to have your patient rinse with chlorhexidine. They ask you to explore the surrounding tissue thickness. Some patients have a mattress of keratinized tissue, and some people have just a thin shell. Again, not as important because you're really not worried so much about measuring the depth of perforation as you are about making sure that you've gotten a good bite through the cortical plate. And again, we're dentists. We use our hands every day. You will feel this. The guidelines are nice to have. So this comes right out of a manual that my Propel rep gave me back in the day when I first started. And this is the 3 easy steps that they recommend. Look at your tissue, look at your x-rays, have your patient rinse twice, 1 minute each, and they give you a little egg timer with chlorhexidine. Then you're going to anesthetize. Again, they're telling you here that you have the option of topical or local infiltrate. And then you're going to go ahead and do your perforations. And so that's demonstrated here for you. The post-treatment instructions to the patients, they may be a little tender around the site. Tylenol only. Aspirin is also acceptable. But you're not going to have patients take non-steroidal anti-inflammatories. Again, anything that stops that cellular inflammatory response slows down orthodontic movement. We do not want to shoot ourselves in the foot. We just created the inflammatory response so that we could accelerate our case, so that our bone would remodel faster. Perforations may be repeated in 10 to 12 weeks, and then you give whatever instructions you normally give for your local or your topical, like don't eat while you're numb, don't bite your lip, those kinds of things. So really, really simple post-treatment instructions. So that is, in a nutshell, microosseous perforations. I'm going to discuss with you now my methods for going in and incorporating this into Invisalign treatment with clear aligner therapy. So welcome to BAM. I have 6 easy steps. I'm going to cover each one, but these are the 6 steps. Pre-treatment information delivered to the patient. I'm going to numb the patient. Aligner prep, and by aligner prep I mean placing all of your attachments and your IPR. I'm going to do my microosseous perforations. I'm going to give my post-operative instructions, and I'm going to close. I do all of this in a 1-hour visit. So let's go through the steps. In advance, you're going to prepare your patient. Setting expectations is key to success in almost anything. So at the records visit or at my initial consultation, sometimes patients will come into you for an orthodontic or Invisalign consult. That's when we talk about acceleration. But if I've mentioned it in the consult and we're going to do this, I'm going to go over in a bit more detail when I do their scan visit. So I talk about acceleration with manual osteoperforations. And what I want to tell you is I want you to get your language down with this. I want you to feel comfortable saying, so acceleration is a separate process. Generally, Invisalign retain aligners are worn for 14 days, and then you switch to the next aligner. With acceleration, we can move you in as little as 5 days, taking your case from 8 months to 3 months. This is the type of language that needs to roll off your tongue. What is acceleration? Well, I use Propel. I take a special instrument and I go to the left and the right of the roots and I stimulate the bone. And in this way, you have an enzyme in your body called cytokine. Cytokine helps us remodel the bone, therefore making it move more predictably and faster. Whatever version of that you feel comfortable with. But I talk about acceleration in advance at my visit. And a patient leaves with my pre-op instruction sheet in hand. I will go over just a few of the things that I include in that. But I highly encourage you to put things in writing. You know, my son had his a surgery for his tonsils. And when he was done with this surgery, I left with a 3-ring binder full of everything he'd ever want to know. What happened? What medications were given? What are the post-op instructions? What could a complication be? When to call, who to call, where to call. So, you know, we give very few post-operative instructions in writing to patients. And I'll tell you, I do it a lot now. So what would your pre-op instructions be? So on my pre-op instruction sheet, I give the indications for use of Propel. We want to increase the rate that your case finishes. We want to make it go faster, and we want to make difficult movements more predictable. And you can explain to them right then, Mr. Jones, that lower canine is almost tipped over into your lip. That's a lot of movement through bone. These are the indications for use. So indications for use, I talk about contraindications. It keeps me in check. I read right off my pre-op instruction sheet. So you're not taking chronic steroids or NSAIDs. Nope, you're not taking bisphosphonates. Nope, great. I go through the pre-op instructions. I tell them, you will be numb for this visit. Plan accordingly. Eat a little something before you come. You know, be sure that you have an hour to yourself after the appointment because you really won't be able to talk or eat. Your lips will be pretty numb. So I want you to be comfortable. You don't want to go back to work drooling. And do not take any non-steroidal anti-inflammatories such as ibuprofen. I name them for them so they know what I'm talking about. 24 hours before the next visit. So that's it. Indications for use, Contraindications, any pre-op instructions, and like I said, I try to be a human being and prepare them to be numb. Patients really appreciate that when they expect to go back to work and they didn't expect to be fabulously numb, upper lip and lower lip, they appreciate that. You don't want a hangry patient in your chair. Tell them to eat something before they come. And again, very importantly, patients sometimes anticipate discomfort for dental procedures, and they'll take some ibuprofen before the appointment. You were shot yourself in the foot before you ever started. So I highly encourage you to make a pre-op instruction sheet. Feel free to copy mine. Indications for use, contraindications, discuss being numb and what you'd like them to do about it, and not to take any non-steroidals. The last thing I put on that pre-op sheet is I give them a glance at post-op instructions, such as Tylenol only during the duration of treatment. We'll give you aligner instructions, change them accordingly. Minor soreness from the initial trays is expected. So when do I place my MOPs? I do them at my initial aligner visit. So step one is giving written instructions, talking about it, preparing your patient in advance. So step two, your patient has come in for your initial delivery, and this is on my proactive when we plan to do this. The key is to numb them up, not to use topical. You need to use lidocaine. I personally use Septocaine, but you need to use a local anesthetic. This is a foot up. I think Propel is a GP product all day long. We have a needle in our hand all day. You numb 1,000 people a day. You know how to do it gently. You know how to talk to them. You know how to touch the tissue. My recommendations are that you do an infiltration on 6, 11, 22, and 27, assuming you are moving both upper and lower teeth. So you give an infiltration, maybe 1 milliliter at each of these sites, and you let that take effect. You may additionally consider giving a little bit midline, meaning between 8, 9, and 24 and 25. I find patients with a little infiltration, all you're looking is to numb the gingiva. I find that it works great, but occasionally you give it to the left and you give it to the right, and the midline sometimes can just be a little sensitive. So I go back after the initial infiltration has taken effect, and I'll give a drop more anesthesia just right around the frenum area, upper and lower. If you are going to use the acceleration and move molars as well, you're going to want to drop back to the premolar area, which the tissue will be numb from your canine infiltration, and maybe give a drop there so that you reach a bit more distally. I tell you to numb them up. You and your patient will be more comfortable, no questions asked. You'll be able to get in and place 2 to 3 perforations. One of the general trends that the reps are telling me about around the country is that doctors are giving like 1 perforation per site, meaning mesial or distal to the tooth. And it's because, I'll tell you, we're good people. We don't want to hurt patients. If you use topical and it feels a little better, but they're still feeling it, you're not likely to do much. It's the same case when you're doing a crown on number 18 and the block isn't effective, you know, and the patient's jumping all over from sensitivity. You know, that's not your best day. It stresses you out. It stresses the patients. Numb them up. Use local, canine to canine. The additional benefits is if you use a vasoconstrictor, you get far less postoperative bleeding. You should get none to begin with. And once they're numb, I'll tell you the second complaint I get about Invisalign is IPR, producing IPR for patients. All that IPR on a completely numb patient is a snap. It's a total benefit. So step 1, prepare them in advance. Step 2, numb them up. Step 3, so I've given my infiltrations. While my patient is numbing up, and before they're too numb to hold liquid, I have them do the chlorhexidine rinsing. Twice, 1 minute each. I then move on. I place all of the attachments in my ClinCheck. I perform all of my IPR. People ask me, all of your IPR? Yes, because if you look at your IPR, and I'm talking about an Invisalign case here, it says on or before, and it'll give you a certain aligner. On or before. So tray 1 is a perfect time to start IPR. Yes, sometimes you'll have teeth that are wrapped around each other, and maybe you wish to wait. Fine. But you get the bulk of that IPR out of the way while they're numb. It's a tremendous time to do it. I do my attachments. I do my IPR. I stop right there. I demonstrate seating the aligners and removing the aligners, however you go through that with your patient. And then I go ahead and I do the propel. I propel away. Step 1, preparation. Step 2, numb them up. Step 3, your attachments, your IPR, all of your aligner prep. Step 4 is to actually go ahead and use your preparations. This is a patient, Abby. We'll be looking at Abby's case tonight. And if you look carefully, you can see my micro-osseous. I took this right immediately after I finished placing them. I put a little pressure on all the sites with my thumb, and I rinsed her mouth out gently, and I took these pictures. You know, the Propel rep had this sheet of paper where I could record where I had placed my preparations. I thought that was archaic. I'm a paperless office. I've been paperless for decades. So I decided, well, I've got a Nikon sitting right here at my disposal I use every day. So I never knew I was going to give a webinar on me teaching you guys tonight. Thank you. I'm honored you're still listening, by the way. And so for me, the sensible thing was, well, I'll take a picture of where I perforated. So you can see in this diagram, whatever you're envisioned with this, this is what it is. You really have to pull the lid down. Where did I perforate? Mesial and distal. These were tight little teeth. You can see in here. I already have done my IPR. It was all done. The attachments are here on the teeth. Just exactly what I told you. Step 3 was to place those attachments and do the IPR. Here we go, up on top, 2 to 3 per site around the teeth. I'm in the keratinized tissue. This is micro-osseous perforations. Bye, Abby. We'll see you later. Step 5, the post-operative instructions. I verbally review with my patient. I sit them up. I verbally review all the post-operative instructions. I deliver in writing an aligner schedule, and I give my post-operative review sheet. Literally, I cheat when I give my post-operative instructions. I go through, again, giving them in writing. So people always ask again, post-operative instructions. Well, I'm both giving the instructions for how I want them to do with their aligners, whether I want them to change them 3 days, 5 days, or 7 days, but I'm also giving my post-op instructions for the micro-osseous perforations that we've just done for the Propel. My sheets have the following information on them. The number of days to change the tray. Change your trays every, and I have a blank space where I write in 3 days, 5 days. Wear each tray all day, every day, and sleep in them. It's permissible to eat in the trays. When I accelerate my cases, I have patients eat in their trays. It is a change up from what you're thinking. They do not get disgusting because they're throwing these trays away every 3, 5, maybe 7 days. I doubt you'll go 7 days in most cases if you're using Propel. So I have them eat in them. I find this is where patients fail. They have every intention of wearing these trays for you. But what happens is they start to cook dinner and they take their trays out and they snack on whatever they're cooking for dinner. It takes them 45 minutes to cook dinner. They have to serve it, eat it, clean it up. Their trays are laying there. Then all of a sudden their Instagram goes off, Betty Lou is on Facebook, whatever it is. They mean to go upstairs and brush their aligners because you told them to brush them before you put them back in after eating. And 3 hours have gone by at dinner, a meal that took 5 minutes to fork back. So eating in them is key. Plus the extra force from chewing on them. You got an aligner seater built right in. Patients are way more compliant. And you need to take control of how patients wear this. Compliance is in their hands, and you need to dictate how this compliance goes. So again, that post-operative review sheet, change your trays every X many days. Wear each tray all day, every day. Sleep in them. It's permissible to eat in the trays. After you eat, brush your teeth, brush your trays, and put them back in. If there are occasional rises where you can't brush after eating, copiously rinse your mouth in your trays and pop them right back in. Discard all used trays, Tylenol only as needed for pain, headaches, whatever, for the entire duration of treatment. And any other things you want to include on there. But those are the things I include. It isn't rocket science, but patients hear you. You go through this list with them and then you hand it to them. Right in their hand, you hand them a list of post-operative reviews. So step 5, review your post-operative instructions, deliver aligner schedules in writing, and review sheet. Highly recommended. Generate one. Aligner schedules. So patients leave with a copy of an aligner schedule in their hand too. And I also write the aligner schedule on the Invisalign bag. There's a little box at the bottom. That is what I use that box for. I write the start date on each tray. Actually, my assistant does in advance. If you do not know where to generate an aligner schedule, this is really easy. Go into your VIP, go into your patient. You will see down here where this big yellow arrow is, generate aligner schedule. When you press on that, this field will appear, and you can fill in at the top. It gives you the start date, which you fill in. It gives you, asks you, how many aligners do you have? In this case, it gives you an example of 32 aligners. How many days are you going to wear each aligner? In this case, 5 days. They gave an example here that if you do this as a MOX case, you're going to save 8 months of treatment. So for 32, you figure in a standard case, you'd be into 64 weeks. You'd be over a year, 52 weeks in a year, right? This would be over a year of care, and you're finishing it in 6 months. It's pretty amazing. But you'll generate this aligner schedule, and then you'll write these very same dates on the bag. So in 2 ways they can look at this schedule. Find ways for your patients not to fail. You will find your compliance increases, the predictability of your cases when they're compliant increases. It's all good. Patients look forward to putting on the next tray. This moves so fast, they're excited to get to the next one. They will wear these for you. And step 6 is the closing. So how I finish my case. I base this example that you see before you on about a 20 aligner case. If you're not moving molars, if you're moving premolars forward, you're going to use Propel maybe from the mesial or the distal of tooth 4, tooth 13, tooth 20, and tooth 29, those premolars back there. So if you're not moving molars, you're in about a 20, 25 aligner case. They're out the door with line aligners, instructions for 5-day wear, recall in 6 weeks. That's how long it takes to go through 9 aligners with 5-day wear, 6 weeks. Usually a 10-minute appointment. You're really checking in on them. You're making sure they're wearing them. You're making sure that the usual things that the teeth are tracking according to plan. And you're normally delivering the rest of your case. Bam! This goes very well. I'll tell you anecdotally, because we live in a give it to me now generation, because patients can see before their very eyes, in a standard case, 6 weeks is delivery of 3 aligners. Can patients perceive movement in 3 aligners? They're moving, right? 0.25 per tray millimeters. Can they perceive it? No. My assistant and I still go, wow, when they walk in for that first recall visit. 10 minutes, teeth will be tracking. Patients will be wearing these. You do all of your checks on that recall visit. Are they tracking? Are things moving? Are there any problems? How's the schedule going? Are they on schedule? And then normally I'm delivering in a 20 aligner case. I'll give them the next 9 aligners. So we've scanned, we've delivered the aligners, we've used our Propel, and we've had 2 visits after that and completed our case. Bam. Let's look at Abby. Abby was the case you saw earlier. Excuse me. So Abby was the case you saw earlier. Abby has a deep bite. Abby's getting married in 5 months. Abby has a lot of parties and plans in the meantime. She looks like, you can see the rotation here on 9. We looked at my pattern on the previous screen where I went mesial and distal to the teeth I wanted to move. I did not move Abby's molars. I think I derotated actually tooth number 3. So my perforations went from the distal of tooth number 20 back here to the distal of 29, distal of tooth 13, and distal of tooth 4. So here she is. You can see that she has an over-eruption of her lowers. The canines splay for me. This is also, this root is angulated in this way. This is not the worst of Abby's problems. When Abby turns sideways and in profile, she's a class 2 platform, clearly, but Abby has an 11 millimeter overjet. It was 11 on one side and 9 on the other because this tooth sticks out so much further. I mean, she's a straight up class 2 platform. So I'm dealing with an 11 millimeter overjet. You can see the crowding from the occlusal, and you can see the crowding here, again, on the mandibular. This is Abby's case finished. I was told before that you can't intrude anterior teeth. I just intruded them. You can see Abby's lower teeth. You can see that there is no longer an angulation. This is crown over root. This is root parallelism. This is the goal of orthodontics. So Abby from, I'm so sorry, hold on, my presentation has frozen for a moment here. So here is Abby after. Where is the overjet? Gone, closed down, acceptable. I did not move her molars. Her bite is locked in. Her teeth are level and aligned. Again, you can look to the before and after and see that we achieved anterior maxillary intrusion. 19 aligners, 13 weeks, total treatment plan. This is your bridezilla cases. These are the women that come to you. I'm getting married in 3, 6, 4 months, and you can now get case acceptance because you're able to treat these ladies and get them in and out of their aligners with their attachments off in 3 months. Bam. Moving on, Anne Marie. 65-year-old woman decided to give herself a treat for her birthday. She was feeling a little shabby, as we all do when we age. I'm looking at a class 2 case here. Again, these teeth, I will have you take a peek at, they are not discolored. They look dark here. Because why? Because these teeth are reclined. You see, they're reclined and they accept light differently. Here's some tracking issues. We're going to intrude these. We're looking at tracking issues. These are blue movements. And this is a rate limiter. This is a locked out premolar. You will see it on the next slide when I give you the occlusal. So you need to start looking at your rate limiting teeth. Here's this. This is a black movement. This is where your case will stop tracking. So we propelled the heck out of this. Medial and distal, 3 perforations each, plus I went around and perforated all of those other mandibular interiors. I want to intrude. This is Anne Marie after. Literally, I wasn't planning on giving it. You're going to see in these slides polishing case because this is the visit that I took off her attachments and I took my final photos. You can see that we have achieved the lateral movement, anterior intrusion, and mandibular intrusion. Again, boop, there is tooth number 29. It has moved. Again, bite locked down. We don't have unacceptable overjet. If you look, we did not bleach her. This is literally the color of her teeth now that they're not in the shadows. 27 aligners. As I said, there were some black movements on this case. 19-week treatment, about 4.5 months. She was super compliant because we were done. Robin, before. Robin's got all sorts of issues. If you notice, 8 and 9 aren't even shaped like each other. So I want you to start looking for these anomalies too in your Invisalign cases. Just as a hint, you need to point these things out to patients because when they look at their case in the first place, they see crowding. When they look at their final cases, they look at, well, these 2 teeth don't look alike. You know what? They never looked alike. They didn't start out looking alike. So this is a heck of a lot of movement. I have some ankylosed teeth for my x-rays. I have tipping, torquing, intrusion. Look at the angulation of these teeth, and it's on both sides. I have almost an overclosure in the back and protrusion in the upper. We have tremendous amount of crowding in the anterior sections, not as bad on the lower. And here's her final case. Again, we achieved uprighting of the teeth, an acceptable profile, little prophy paste in the corner there, before and after. I went back after this premolar, this canine. This was a tremendously difficult movement. This tooth was almost completely locked out, and I went back after it with 12 additional aligners. People asked, did you reapply for Propel? Yes, I did right around this. There wasn't anything else to do here. So 24 trays at 5-day wear, and these are older cases. I might have moved the additional aligners in 3 days since I went ahead and propelled again. But in about 6 months' time, I took this case that would have been, I don't know, good 2.5 years in brackets and wires, and I moved her teeth. Katie. Katie is the biggest diastema I have ever treated. This was at least an 8 millimeter diastema between the widest sections. If you'll also notice here, I'm highly concerned with black triangle finishes because these teeth are also very triangular in shape. She had a frenum that attached from the wet, dry border of the lip all the way under. This little pink bat here you see hiding in between. Totally fibrotic tissue. Yes, we did a frenectomy on this case, but she's also overclosed in back. In this case, I did upright molars, a pretty predictable movement. Expansion, not so much. Uprighting, buccally tipping, a more predictable movement back here. If you go back to the previous slide, let me just go back for a moment, you'll notice that there's almost not enough clearance here. While these teeth are not overly erupted, the problem is that the collapse in the back. These are flared tremendously. This was a heck of a case. I set this case up and I'm taking my photographs. Not only do I have this tremendous space, I also have other diastemas in play up here. There is a lot of closure to be involved, and I have lower crowding. And if you remember, Anne-Marie's locked out. This is a lesser version of this. Moving this teeth through these other teeth is a less predictable movement. I used my perforations. I did this in 2 steps, and I'm very proud of my finish. We knew, I IPR'd in here, and getting this kid who had an 8mm diastema to allow me to reshape these teeth with something, but I wanted to try organically to shove the teeth together enough to get closure. I'm going to let this was taken the day I finished the case. We bleached her that day. We took off her attachments and bleached her, and I told her, give this 6 months and let's see how the tissue responds. We uprighted these teeth. You can see I've got a nice bite now. Her VO is better. I've got an acceptable overjet and overbite. We did this in 2 phases. I knew that 8 and 9, the first easier movement that those two would do is they would tip. So in the initial 22 aligners, I got closure of 8 and 9, but only at the incisor. And in the additional 14 aligners, I planned a phase 2 for her, is what I called it. We continued the uprighting, but about 5-6 months of care, and I took this kid from here to here, completely upright, parallel roots. Bam, is the power of being able to move your teeth. Katie actually came to me on a veneer consult. I was a second consult. Someone told her they were going to put veneers on her teeth. I said, I do a lot of veneers. I've never seen 9. You need a tooth in the middle. If I had not been able to do this in a very rapid period of time for Abby, my bride, or Katie, my very impatient 22-year-old who paid for this with her own money because she was so upset about the spacing and her appearance, I would not have won the day with these cases. I'll tell you that inadvertently, the ability to accelerate sells cases. So the way I see it, and I'm going to speed along here, we're running a little late, the advantages are the ease of use. It takes no time. There's no extra visits. You're applying this on your first visit. It's inexpensive relative to other techniques. The case finishes way more than 60% faster. It's less visits, less chair time, happy patients who go out and tell other people, it took her 3 months. And less visits and less chair time for you, what are you worth per hour, per half hour? When I'm finishing these cases, all day long, this makes my Invisalign cases profitable. I get so much chair time back and referrals. It sells cases. Again, my Bridezillas, I can get you from here to there in 3 months before your wedding. Teeth move better, which again makes the move faster, makes it more profitable for you not to have additional aligners and additional chair time. I'm in control. You know, with some of the other acceleration techniques, you not only need your patients to wear their aligners, but you also need them to do whatever the technique is. With the Propel, I've done the procedure. It's one and done. It's working. The downside, there really is a little downtime. They're numb. They have to let the anesthesia wear off. It's not a big deal. I have to use a needle. Some patients don't like needles. You know, I think these are minor, but this is. You can have a bit of post-treatment bleeding. It's not a big deal. Again, 10 minutes of not touching the tissue. The real crux for you, as I see it, is it takes time to educate your patients and to really train your staff. You can't have your staff walking around, she's going to stab you in bone. That doesn't work. It isn't what you do, first of all, and it isn't the language that's respected or used. So it takes time. If you want to be successful with this, take a little time. Talk to your patients. Talk to your staff. As soon as your staff sees you complete the first case, they will be blown away. They'll be yours for life with it. Some people like ibuprofen. It's habit. You know, in the 80s, everybody took Tylenol. In the 90s, everybody started taking ibuprofen. A minor issue. Slightly longer initial visit. So if you've never done this before, give yourself 30 extra minutes so you're not sweating. Maybe 10 minutes once you're a little proficient. I do all of that aligner delivery and Propel in an hour. It takes me about 5 minutes to do the upper and lower with the power driver. So pricing. The price for the units for either the RT tips or the burrs for the PT are about $100 and $150. Some doctors charge $500. I see this as reasonable. You're giving patients 6 months of their life back. They have soccer practice. They don't want to keep coming even for 10-minute visits to your office over the course of a year. They appreciate getting their life back. It has value. People ask me what I charge nothing. My cost is about $100 a burr. My case finishes in 2 to 3 visits. I have way less refinement and habit, patient and doctor. I charge nothing. I've lowered my overhead by getting all my chair time back. I roll it right into my fee. And that, my friends, is microosseous perforation. Let's talk quickly about the VPro 5. This is high-frequency vibrational device. Separates itself from Excelodent, which was low frequency. Excelodent in a day, if any of you use them, 20-minute patient use. This is 5 minutes wear a day. Everybody can find 5 minutes in a day. I will tell you, I tell my patients to do this at night, right before bed. Brush your teeth, put your aligners in, turn your device on. You're going to push this little button right here. It turns on. It turns itself off after 5 minutes while you're setting your alarm, getting your drink of water, putting the dog out, letting the dog in. 5 minutes. End of the day. Best time to do it. They wear their aligners all night. Their trays are fully seated. This really does advance your cases. This comes in pieces, which I'm going to tell you to assemble for your patient. There's the mouthpiece that goes in the mouth, as you suspect. This is the engine, the motor, if you will. This connects together, and you have a UPS charger, just like your cell phone. It also comes with a flash drive that you're going to monitor usage with. Very, very easy. Your Propel rep can help you set that up. So here's the delivery. I remove the device from its packaging and I put it together and I charge the device for the patient. Because while I'm giving my post-operative instructions, I push the little button and they do their first acceleration right in my chair while I'm giving instructions. It hums, kind of like an electric toothbrush. It starts up slowly and it ramps up a little bit. It's very quiet. It's kind of a good feeling. So charge the device. You're going to assign the device with the flash drive that allows you to assign a device per patient, and now you can track their usage. It's really super easy and convenient. So you're going to connect the device for the patient. You're going to press firmly on that button. This is not a touch screen. You're going to have to push the button, and it'll turn on. It ramps up, as we said. The device will go for 5 minutes and shut itself off. This LED light, I'll show you the light. You can't see it in this particular slide. It gives you light notifications, just like your cell phone does when the battery's low, when the battery's charging, when it's in use. This could not be easier. So here's your device notification. Blue means it's active and wearing. When you push that button, this light turns blue. My daughter, who I use this device and used to lay in bed and make the light dance on the ceiling because she did it every night right before she went to sleep. Green, when your cycle is completed and the device is fully charged. Red, if you interrupt a cycle for any reason. Magenta, it's low battery. And amber, you've got it plugged into the charger. The software is simple to use. You're going to get charts like this on your computer after you download the software. I always wanted to get one of these. No, not compliant. Silly faces. But this actually allows you to monitor. So, and if patients, here's the deal. If patients are using this device every night, you can bet they're following the rest of your instructions. Let's look at Jamie. Jamie was that movement assessment chart that we talked about earlier. This is a really difficult case. Jamie is 16. She has 7 missing adult teeth. These are baby teeth. These are actually undersized adult centrals, but they look huge here because these are undersized teeth. To complicate this case, Jamie had baby tooth, baby tooth, baby tooth, baby tooth, a lower baby tooth, and some in the back. She did have her adult premolars. About the age of 13, when they first came in, Jamie took a nail polish bottle, put it between her premolars because the lid wouldn't come off, and twisted. She split 12 and 13 irreparably down the middle. Here are the baby teeth on Jamie. You can see the lower canines are also primary, as well as that central. Here is her right side, adult premolars also undersized. Here is her left side. She was left in the care of her pedodontist after these teeth were removed, and her orthodontist at the time. No tooth retainer was placed, and 20 and 21 over-erupted into the gingiva here. There's actually a white spot on the gum where these teeth over-erupted. This is the black movement you saw on that movement assessment chart. So Jamie's case will not be a wow finish because this is a pre-prosthetic result. No one can get an implant into Jamie's mouth with those premolars where they're positioned. So I set up a prosthetic case with Invisalign on Jamie. Initially, she started out in normal wear. She liked wearing her retainers. If you look at this case, it looks like I did not achieve enough intrusion. I want you to keep in mind that I'm going to open the vertical dimension with restorations in back. So these teeth are ideally placed to where I want them to be, given that I'm going to open it up on the back. She used the V-Pro 5 every night, really faithfully, from about halfway through the case. She got tired of 14-day wear. I moved her to 7-day wear, and you can see the attraction. What I really want you to see, excuse me, I moved way too fast for you there. What I really want to see on this is I achieved adult premolar intrusion with the V-Pro 5. I also placed Pontics here in between, and I had to fight the Invisalign to place them, but I wanted that additional force. So I appreciate you being patient with me with this. The last thing I'm going to say is that from your Propel reps, who are wonderful, by the way, I travel lecturing for Propel across the country, and I've met a lot of your reps. They're really genuinely nice people, eager to help you succeed. Get these flyers from them. These are all the patient's instructions that they'll ever need with the V-Pro, and they're tiny, the instructions that actually come in the packaging with the device. I like these better. They look more professional. Ask your reps for these. So I'm going to open up the field for some questions. I so appreciate you hanging in with me tonight, and for those of you who are going to sign off, thank you. I'm Dr. Anna Baric, and I hope you have learned this procedure, which has made me so successful with my Invisalign treatment. So I'm going to pop in here, and I'm going to look for some questions, guys. Question number one, is this the only audio webinar? No, there are webinars actually available. Talk to your Propel reps. Mine is not the only one available. I probably talk about more of case integration, and my technique for accelerating my lectures definitely are more in depth, and we talk about some of those things. What are some of the challenges I came across when I did my first Propel case? That's a funny question. Hi, Roxanne. Actually, I didn't wait for my rep. I was so eager to get started. I talked to my first patient about it, and right away, I said, I included the price. I was going to initially charge $500 for it, and I started in. I talked to Bobby, actually, and I said, hey, Bobby, you know, I've got this incredible technology at my disposal. It will need me to numb you up today, but I will do it at no charge, and off we went. I didn't have a complication. Does the insurance help to pay for this? Yes, a lot of times there is a periodontal code. Some of the insurance companies require photographs. I'm not allowed to give the code out per se over that. Again, your reps are so useful for that kind of information. So that's how you're, and I am finding from people who respond to me, who I've taught lectures to, they're getting some reimbursement for insurance under the periodontal codes. Do I have any patients who refuse MOPs? No, not really. I don't. It's really at no charge. I mean, and nobody tells me, yes, Dr. Baric, I'd like to move my case way slower and less predictably. If you nail the benefits before you talk about any of the rest of the procedures, if you get your language comfortable in your own words, patients are jumping at it. They are jumping at it. For that frenectomy case, did you do the frenectomy relative to the Invisalign? I wanted Katie to do the frenectomy at the beginning because I figured that's additional inflammation, but she didn't do it. She was more afraid of the frenectomy than she was of anything else we did. So I actually had to jump on her and get her to do it, and she did it before I did my additional aligners. I told her I wouldn't finish her case unless she did it. I have a periodontist at the practice. He did a beautiful job with her. Is it possible to use on a patient with periodontal disease that's under control? Yeah, controlled, absolutely. They're great patients to move teeth on, and a lot of that perio shows up around your mandibular incisors that are over erupted. So intruding those teeth, if it's possible, you can actually get these teeth to intrude for you. Do I ever have difficulty getting profound anesthesia? No, you're not looking for extraction level. You literally are looking to be able to poke and explore into the gum and not have the patient feel it. The bone has no nerve endings, guys. Keep in mind that the bone is not innervated. You can cut bone in half. It's the gum tissue. All you're doing is numbing up a little gum, that little bit of infiltration, all you need. Maybe a little additional distal, or, and I said again, mesially. No, I never have problem. I do not reuse the Propel tips. The same reason for that surgeons do not use scalpels. Again, things dull. They're at such a low price. I get a new one every time. Any age restrictions? Hi, Maria. No age restrictions. I did Propel on a 13-year-old the other day. I did Propel around. I used the carrier distalizing appliances. I used my microosseous perforations for that as well. If I'm distal, this happened to be a class 2 case, distalizing those canines with a carrier appliance. Just like you saw in that NYU case study, I went distal because I'm moving those teeth distally to the teeth I wanted to move. I didn't Propel any other teeth. No age restrictions. Kids handle it better than adults. They don't care. They want to be in and out of them. I get more case referrals from accelerated teenagers than I do from anywhere else. They go into school with those things, and bam, you got the whole grade. When the drill still sounds different from a tooth, how long do I keep them retainers? Gregory asked, how long do I keep them in 24-hour retainer use after treatment? I don't do anything different with the MOPs. I have my exact same protocol. Stick with the protocol you learned or that you're comfortable with. There really is no change to protocol because you have to figure you lose all of the benefits from that activation in 10 to 12 weeks. So as long as you're going 10 to 12 weeks with your case, it's gone. It's either going to retain just as they normally do. If you did a case in 8 weeks, I might consider 7-day wear with the trace, just so you're getting to that 8-week point. In that case, if you figured the case up that quickly, I would keep them in retainers for another couple of weeks around the clock, but only if I finished. Is there any root resorption with cases? I get asked this a lot, James. There are no resorption cases that I've ever seen. Root resorption is not based on speed, it's based on force. The force of your Invisalign trays, if you're doing clear aligner therapy, or your NiTi wires, are exactly the same. So root resorption is not an issue. You're actually moving it through a less dense medium. You're making it much easier to move the teeth. Resorption is a great question. So can you comment about 5-day wear? Why not 4 or 3 or 7? So we talked about how difficult the movements are. That is the basis. What type of acceleration, how much acceleration, and what's the most difficult tooth to move in that mouth? If that is a black movement, you're in 5-day wear, in my opinion. I do move down to 4 days and 3 days. If you thought for a minute you don't have difficult movement here, you just have a lot of simple crowding to correct, I would say you can go down into 4-day wear. You know, a great way to do it is that don't write it in stone. Start your patient at 5-day aligner wear for the first couple of aligners and say, do they feel loose around day 3 or 4? I want you to tell me when you come back. Bring them back in a couple of weeks. Yeah, they feel loose, doc. They're pretty good because that physiology of the patient differs from patient to patient, not just the tooth movement. If they're comfortable, move them into 3-day wear. The rationale between 5-day wear, teeth generally move. That's the real rationale. Any use for a VPRO 5 at the retention phase? No, Phil, there's no benefit to using your VPRO 5 in retention. Retention, you want to do just the same. I have heard anecdotal things about, but you're really not trying to, seat your retainers. Your retainers should glide right on if your case finishes. So I want to thank everyone so much for hanging out with me. I know I ran late. I tried to give you the best of me tonight, and I appreciate all of your time and attention. Good night and good luck. Use your reps. They're wonderful.